University. Welcome to the third webinar of the Modeling COVID-19 Pandemic series, brought to you by the China Data Institute and the Future Data Lab, as well as China Health Policy and Management Society. This webinar is sponsored by Taikang Luojia Research Institute based in China. I would like to thank you for our organizer, Dr. Shu Mingbao, the director of China Data Institute, for his support on the important effort. Dr. Bao recently retired from the University of Michigan, and he initiated the China Data Center in the University of Michigan. And I believe lots of our participants have heard or used the data from the China Data Center. He has been hosting more than 40 COVID-19 related webinars through the pandemic. More information on the webinars and recordings of the past webinars are also available on the website of China Data Institute or the WeChat groups. We are also grateful for the input of the board members from China Health Policy and Management Society, like Dr. Qi Zhang, Dr. Chen Zhuo, Dr. Xi Chen, who is actually also the presenter of today's webinar, as well as Dr. Li Zhengshi. The purpose of the series of the webinars is to explore various models that have been using for study COVID-19 to inform policymakers, public health, and healthcare professionals, and to the public. On today's webinar, we're going to discuss the COVID-19 related policies in the context of the ongoing COVID-19 crisis. There has been various travel restrictions in different countries, and there has been debate of the effectiveness of these restrictions that we're going to discuss today. And in today's talk, we have two presenters to share their research and thoughts of the COVID-19 related policies. After each talk, we will also invite a discussant to share their reflections of the presenter's talk. Our presenters and the discussant will all have really deep interest and extensive experience in health policy. We will begin with Dr. Xi Chen to talk about the study measuring the optimal designs of travel restriction during COVID-19. Dr. Xi is an associate professor of public health, affiliated faculty of the Department of Economics at Yale University. He was also the president of China Health Policy and Management Society from 2018 to 2020. The discussants for Dr. Chen's talk is Dr. Shi Wenye, and our second Dr. Chen recently graduated with his PhD in economics from Stanford University. And then we will have Dr. Wenli Ye to talk about the importance of the broader COVID-19 policies. Dr. Ye is a professor of practice of global health policy and economics in the Department of Global Health and Population at the Harvard School of Public Health Department. She is also the director of school-wide China Health Partnership. Then we will have Dr. Li Mingcai to discuss Dr. Ye's talk. Dr. Cai is an economist of the Center for Medicare and Medicaid Services in the U.S. Dr. Cai was also a demographer of the National Center for Health Statistics. So each presenter will have 35 minutes, and each discussant have 10 minutes for your talk. For our audience, if you have any questions to the presenters and the discussant, please enter your questions in the Q&A box. We will answer your questions at the end of each talk. Please make sure to mute yourself all the time during the talk. If you logged in through your computer, you will be automatically muted. But if you enter the meeting using your mobile phone, you will need to mute by yourself. The webinar will be recorded, and the recording will be shared in the WeChat groups and sent to your email if you register talk in advance. Okay, Dr. Bao, do you want to add anything else?
No, just go ahead. Yeah.
Great. Okay, so
good job.
To get started, I'm going to turn this over to our first presenter, Dr. Xi Chen. Dr. Chen, it's your time. Dr. Chen, I think you're probably muted. Yeah, please unmute yourself. Yeah.
Thank you so much for the organizing committee, and we are also very fortunate to have Dr. Winnie joining us from Harvard. So I think the arrangement is perfect because it allows me to throughout a break to attack the jet. And also you say that the discussant for my paper is our study is also Dr. Chen. So since we have the same last name, so we should be able to treat each other nicer, right? So great arrangement. So let me start. So this is a very fresh new project. So on the optimal travel restrictions in epidemiology. So this is a joint work with colleagues Zhou Yun, Professor Zhou Yun and Professor Xu Wei from Jinan University Institute for Economic and Social Research, and also their student Yu Pei. So all the arrows are mine. So briefly introduce our motivation about this study. So we know that population flows have been shown to strongly predict the spread of COVID-19 across space. It's just very contingent for this COVID-19 in terms of human-to-human transmission. And all the countries at the beginning of the epidemic were having no other solutions. Without drugs, vaccines, therapeutics, it's hard to address this issue. So most often, the country's economies resort to certain type of travel restrictions or even lockdown. Those are called non-pharmaceutical interventions. And but we already experience or see all the lockdowns throughout the world. So some are very massive and may introduce very large social costs, especially if for some areas without anticipation of those restrictions before the lockdown. So that promoted us to think about whether we should think about optimal way, a better way to have the lockdown or implement the travel restrictions to reduce the cost and also mitigate the virus transmission. So with that, we thought about maybe we are not introducing a lockdown of the whole city, because when you lock down a whole city, it means that you cut all the traffic, all the travels between to and from the city with the outside world. Maybe some route-specific travel restrictions can be very helpful, especially at the beginning of the epidemic. And especially when the epidemic usually started in very isolated, sporadic locations. So that makes some route-specific interventions more effective. And also with those travel restrictions, we could think of the implication of this study to suggest some ex-post management. For example, we are not, in some economies, we are not able to lock down. But if we know the travel history of certain or specific travel routes, maybe we can track those individuals with higher risk and with the advent of the mobile technology, if we understand, we know the information about travel history of individuals, we can access that and we can implement the contact tracing, screening, and quarantine more effectively than systematically or quarantine people without a certain travel directions. So those we call it ex ante if we can restrict some travels. And also ex post if we can better manage population travels with certain characteristics, then we might be able to better mitigate the virus. So, how to move to the next page? perhaps the
Dr. Chen, I think you probably select a model to mark your
yeah,
slides.
maybe, okay, I think it's good. Now I change to the other one. This is the next. Okay, so
That's great.
So in this paper, we explore the possibility that travel restrictions can be imposed to specific routes and examine the optimal design of such policies. Okay, so besides incurring the lower socioeconomic costs, some route-specific travel restrictions can be implementable when the massive lockdown is not feasible. So we embed a parsimonious model of spatial spread of the disease in an optimization problem. We take it into consideration the cost of disease infections and also the loss of the economy. So as a social planner, as a decision maker, we need to weigh the balance between reducing the infections and also not hurting the economy too much. So the optimization problem is solved from the perspective of a social planner. So if some audiences took a public economics class, we know that a social planner will try to maximize the utility of the individuals in the whole society, but not the individual sector. And we try to solve the optimization problem under the constraint that each city may act independently without coordination. Sometimes we could coordinate to some extent. For example, in America, some northeast states were forming a group to restrict the travel from outside of the states. Try to have a Zoom that can restore economy earlier, but try to safely reopen. So that was something was done by New Jersey, Connecticut, New York State, some nearby states. And those are some coordination. But generally, in America, we know that there's no national plan for lockdown and reopening. So most often it's uncoordinated mode. But we know that when there's no coordination across the states, something may happen because virus transmission, no boundary between states. There, as a public good of implementation of the lockdown or travel restrictions, it hurt the local economy, but it benefits others. So it generates positive spillover to other states. But if we are not having a coordination or coordinated efforts across states, that means that each state may have to impose even stronger measures in order to counter the inaction of the nearby states, which may not be optimal. So we will show that with coordination, the social planner can do even better in curb the virus spreading with lower cost. And we will illustrate this as an example using the epidemic data in China from all cities and the citywide transmission of the disease. So in total, we use like 360 cities. So the optimal policies, there have been some studies recently. One notable study is by House and co-authors looking at comparing coordinated and non-coordinated shelter-in-place orders. And they find very interestingly, if these states are not taking any action, but nearby states are all taking action, it is equivalent to this state also being implementing the shelter in place. So that shows there is a spillover effect taking effect towards even for the states not taking any action. But the spillover effect is built on the sacrifice of nearby states. And that study is also using the social network data, trying to show that even for two distant states like New York Florida, they may still have a spillover effect because the compliance of shelter in place in New York may have a positive spillover to Florida because people living in Florida may have family members or friends in New York State, and they may interact with each other in social network, which may also promote some positive and coordinated efforts. And some other studies also try to do this, but most often those studies are either using epidemiology models or they try to look at one single unit about the optimization decisions of that unit. But in our case, we try to look at all cities in China, and each city is one unit of decision maker, and we try to look at the difference between the coordinate and not coordinate. And we try to use not use epidemiology models. If you attended the last two webinars, you see that our previous speakers already summarized the difference between epidemiology models and some social economic models. So this time we will be using some economic models to do the causal inference, try to estimate the causal effect of transmission, using those parameters to calculate and compare the coordination and non-coordination. So this study also may link to the social network literature. In the social network literature, however, they usually not look at the change in the pairwise change in the link, like what we do, like restricting the route-specific travels. Most often, they look at removal of a node in the network. For example, if you are familiar with social network study, you look at the heap layer in a network, and if the removal of that heap layer have an effect on the spillover effect on the economy or society or the community. But in our case, very unique. We look at the direct link and the change in that strength of the link between the two cities and how that can affect the overall equilibrium. And we will show that the effect of a link, the change in the strength of a direct link of the travel between two cities will be a function or will be affected by the centrality. We measure it as the centrality of the location of the original city, the city of origin, and the centrality of the destination. We will show that in empirical example. So our results can also be extended to spatial interaction models where agents take network as given and the social planner can alter the strength of the network. So, so in this model, this is basically the model we are estimating. Yi is the infection, the cumulative number of COVID-19 infection in the city I. And Wij is the link. The link is measured by historic travels between from city J to city I. And we know that each city was linked with multiple outside cities. So this essentially will be a vector of linkage between the city I and the city city I and the city J. And the Yj is infection number, the cumulative number of infection patients from city J. And here, Ti is the infection number in the home city. So that's why we distinguish the transmission of the local city as well as the transmission from outside. So the lambda measures the spillover effect of nearby cities in the network, the transportation network affecting this city. And we here we can see that we measure two things. One is that we need to measure how the people travel from city Ji and G1 to G0, affecting the infection in the Yi. So that means we only look at the link specific change on the individual city I. And we also want to look at the equilibrium effect, which is the overall change in the change also in this link, but not only to the city of origin I, but also to all the cities combined. So that would be the equilibrium outcome. So we measure these two, and the derivation of the model the paper will be released very soon. And in the paper we derive what matters. So although it looks technical, but I just want to give you intuition about that. So here in our case, the policy targets the value of a direct transportation link between city I and city J. So through the, for example, ex-ante restriction of route-specific transportation or ex-post contact tracing on the current measures, like what Taiwan has been doing. We monitor the travelers from Wuhan and quarantine them or order tests to them or do the contact tracing to specific travelers from Wuhan city. So here on the left-hand side is the change in that direct link between two cities on the overall effect of the change in infection in the whole economy. In our case, it's China. And this is determined by three items. One is the spillover effect, how large the spillover effect can be. And the spillover effect can be estimated by the basic number of productive number, which was already offered in epidemiology studies. Or it can be based on some previous estimations of other kind of disease. And these two terms are very important. One is the centrality of the city of origin. So let's think about Wuhan. Wuhan is the epicenter at the beginning. So if Wuhan has very much a large centrality influencing nearby cities, then this effective size would be very big, influencing the overall number of infections in China. So we needed to restrict the travel from Wuhan in this case. But restricting the epicenter or the transmission origin may not be enough. We need to think about all the potential destinations. So we think about Wuhan can be linked to 100 cities. And some cities are very large cities and can have a spillover effect and affect many other cities. Like Guangzhou has a direct link with Wuhan, and a lot of migrants may travel back and forth during the year, especially before the lockdown of Wuhan and before the Lunar New Year. So Guangzhou would be a very high risk destination cities because Wuhan will, so the Guangzhou will have a spillover effect to many other places in China. So we really needed to be very careful about not only restricting the outbound travel from epicenter or the cities near epicenter with high risk of transmission, but also the destinations of those epicenters. So that's why we need to think about the route-specific travel restrictions. And before we show the results, we measure the optimal list of travel cities and priorities. But before that, we need some key parameters. So we estimate the model parameters using data from confirmed COVID-19 case in China, and we measure that at the city level. And in measuring this, because we know the transportation and the transmission of virus from all the city J to city I could be endogenous. So that's why we followed our published work in Journal of Population Economics to instrument those two endogenous variables, which is the number of people traveling between from J to I, and the transmission number of people infected within city I, the home city, and also the weighted average of this the travel strength between city J or city J to city I, and the infection in city J. this shows like a weighted average of all the transmission from all possible city J, which has linked with city I. And we use that, we use ZJ as instrument. ZJ is the local weather conditions. So the ZJ means the weather condition of city J. Because we know weather pattern is a critical factor of like precipitation, temperature. Those are the major factors in fact affecting the transmission in city J, and which may through city J and through the transportation may affect the link to city I, and the weather in city J should have no direct correlation with the transmission in city I, which is YI. And here is the estimates. So here shows that this is we just show you the OAS estimates and our instrument variable estimates, which shows the causal inference estimates are very similar, slightly larger because there might be some reverse correlation effect, which drive up a little bit this parameter. But this 0.258 means that a 1% increase in infection in a city J, where 100,000 people travel to the city I, will cause 0.258% increase in the number of cases in city I. So which give us the transmission number, the parameter. This is number is a critical parameter for us to evaluate the coordination, non-coordination, and the welfare effects. And we also use model B. We can skip up about that, but this model B is using a different sample. We just want to show the robustness, and because model B was using the sample before the Wuhan lockdown, so the travel was not even being affected by the concern of the virus spreading. So during that time, the infection should be more exogenous. But basically, they show us very similar results. Now, let's think about it as a governor or as a social planner of the economy. We need to weigh the balance between reducing the infection for every city I. So overall, there are 360 city I in the sample, in our sample. So we want to have smaller this term. And this term shows the Wij is the travel between city I and city J. And here is the, this term shows the average cost of this travel. So we also want to mitigate this term because with more travel restriction here, so the phi ij is the size of restriction, so ranging from 0 to 1. 1 means that the travel between city J and city I was not affected, but if equals 0 means the travel between city I and city J is banned. And this second term is economic cost. The first term we can think of as the public cost, public health cost. We try to minimize the overall two terms together. And we can solve this. And if you're interested in this understanding how we derived this model, we can skip this. And finally, we before reaching the conclusion, we want to show that here YI is the infection in city I, but we know that when you are faced with a pandemic, the city mayor may not have any idea about what could be the case. Like Wuhan could be the worst case or could be in the relatively better case. So there could be uncertainties. So the model also takes care about uncertainty. And if the city mayor is risk averse, then the model can be modified to incorporate this risk averse decision maker. So we can introduce a concave function in order to incorporate that risk aversion. So after all these derivations, you can see we have like 4 or 5-page derivation about this social optimal optimization process. And through that process, originally think about if you have 360 cities. When you want to impose the route-specific restrictions of travel, then you have like 360 to the power of 2 type of parameters to manipulate, right? Because city I to j could be phi ij is a parameter, but city j to I will be phi ji. So you have so many parameters. But through our optimization process, we're able to down to push down the number of parameters to be estimated, gigantic number of parameters to only have 2 times n minus 1. N is the number of cities. So that means that it makes the computation possible as a decision maker for the whole China, or each city-specific travel, what's the optimal restriction? We can measure that as a result of reducing the dimension of these parameters. And here, this is, so far we talk about everything about the coordination. Because if you look at this function form, this is a summation of infection from I, but all the I's. So as a social planner, you want to minimize the infection all over China. But if there's no coordination between cities, then it's in a different world. Each city will just try to minimize their own infection. And GI is the cost attached to each infection, and the cost is specifically public health cost. So in this world, without coordination, things will be different. So let's jump to the results. And here we show that if you the horizontal axis is the percentage of cities being locked down, so completely locked down. Now let's not think about restricting some between 0 to 1. We just lock down to phi ij equals 0. And if that's the case, if we want to only have the maximum number of cumulative number of infections as we have today for China is around 80,000 some infections all over China until today, then we only need to lock down about 5% of cities. If we city pairs, we do not need to lock down all over China. So this is just to give an intuition that when you are doing the route-specific restrictions of travel, you do not need to lock down the whole country. Only 5% of the links between cities need to be locked down. And here, we further make the model flexible to allow not only lockdown, but some restrictions between 100% to 0%. So each city can select the percentage of travel they can reduce. And here shows from the social planner point of view, if you think you are president of China, premier of China, so you can think about the top list of cities from our social planner problem that needed to be restricted as an outbound city. So first, not surprisingly, is Wuhan. And Wuhan, we have different parameters to show the range of the estimates. But in every case, you see that the horizontal axis is the size of the restrictions, the intensity of the restrictions. So here shows that the restriction of the intensity of travel is approaching 1. That means in an optimal world, when the government or decision maker consider about overall reduction of infection and overall economy loss, they need to almost lock down Wuhan. And those are the cities also high ranked. And if you look at those cities, very interestingly, they are all, the top 10 are all from Hubei province. So that means this is very similar to what already or actually being done in China when China locked down Wuhan. And consequently, the travel between Wuhan and outside city are all suspended. And further, after a few days, they locked down Xiaogan, Huanggang, Hezhou, and Jingzhou, and many other Hubei province cities. And after a few days, the whole Hubei province locked down. And this is consistent with our model because our model, one important term, as I showed, shows that the centrality of the epicenter or the city near the epicenter is critical to be restricted in order to have the optimal restrictions. But interestingly, we also see some other cities outside Hubei province that need to be prioritized to be restricted, like Wenzhou, like other Chongqing, other cities. And this is from the perspective of which cities we need to ban or restrict the travel to some extent from outward transportation. Let's now think about from cities who need to think about which cities they need to restrict the travel from. So from Wuhan, and here is another list. Here, the top one is Guangzhou. So as a mayor of Guangzhou, they need to think about Wuhan. They need to first restrict the travel from Wuhan, and also the Shenzhen decision maker also need to think about banning or restricting here, because this is pretty much approaching one. All those cities need to immediately think about prioritize the travel ban or restrictions from Wuhan. Those are the top list of cities which need to restrict the intensity of outbound restriction from Wuhan. And very interestingly here, if you look at Beijing, so from the outbound restriction point of view, Beijing is a city we need to restrict the outbound. But there are two scenarios. One is the function we call the coordination social planner. So if all the cities can coordinate with each other, compared to without coordination, you will see that in each parameter, you will see that the restrictions of coordination is smaller than non-restriction. That's very interesting result. That means when all the cities acting together, there will be spillover effect. So the cities may not be acting as stringent as they did independently. So the spillover effect will reduce some of the travel restrictions for some cities, which will reduce the economic cost and other costs to those cities. So the coordination may not be a bad thing. It doesn't mean that some cities may act first and hurt their own economy. Sometimes that means smaller restrictions can be implemented to achieve the same goal. And these are the two. And here show exactly if you are a policymaker in China, there are we know that there are two different worlds. One is without any travel restrictions. What's the population flow between cities, between each pair of cities? But from our model of social planner and coordinated social planner problem, we also know that what's the optimal travel flow between cities. So the difference between these two will be showing us which set of cities need to strengthen the regulation, the travel regulation, and some small specific cities may need to may have some room to lose their restrictions on the travel. So here are this map shows the cities that have with negative difference. That means the optimal difference at optimal travel restrictions is smaller than what they already actually did in restricting travel. So then this arrow point to the city of destination cities and origin cities. Those are the pair of cities, the top 50 routes in China. Definitely, there are 360 to the power of 2 pairs. But those are 50 routes can be, the regulations of travel can be loosened. And in comparison, there are 50 top cities need to strengthen their travel restrictions because their optimal travel restrictions impose even stronger travel than what they already or actually are doing. So here, especially if you look at some cities in Guangdong province, Guangzhou, Shenzhen, those are the cities really needed to strengthen their restrictions in order to match their optimal travel restrictions according to the coordinated social planner problem. So here is the conclusion. So we find the marginal effect of decreasing intercity population flow in reducing the total infection. And it's not homogeneous. It really depends on the position of the city of origin, like the epicenter cities and those surrounding cities. and the destinations like Guangzhou, Shenzhen, Beijing, those cities with major network of population flow. So both the destination cities and the city of origin play a very important role. And we applied a theoretical model to the data on the spread of COVID-19 in China. And the model framework of this paper could also be applied to optimize the public health measures in response to other infectious disease where population flows significantly contribute to the spread. So, so far, I think multiple countries already implemented some, as I mentioned at the beginning, the travel restrictions, but I think thinking about the optimal travel restrictions and balancing the immediate economic cost and cost to the public health would be very important. And this study may not only apply to the ex-ante travel restrictions, but also ex-post measures of travel restrictions. For example, in mainland China, the health authorities already been using, for example, migration maps to connect the real-time data on the location of people via mobile phones, mobile payment, and the social media. So that can help health authorities to track the movement of people who moved out of Wuhan and other epicenters. So those data can be helpful to be used to implement this model and have the policy making to be more optimal. And in Taiwan, even more, they are not only linked that to the travel restrictions, but also they use migration record using those mobile data and other things to link that with the medical record, insurance record. So the doctors, when they see the patient from a certain area, they can order the test, they can perform the contact tracing and quarantine more effectively. So all these systems are linked. And in South Korea, they also use called facial recognition technology, bank card record, and GPS data from the vehicles, automobiles, to provide real-time data for the detailed timeline of people's travel, which also facilitates targeted screening and quarantine measures. So, so we hope this model could help the policy making in the future. But so far, as you already see, this is very preliminary and it's a static model. Eventually, we want to make it a dynamic optimization model because the policymakers, social planners will decide on their action in the next phase by the infection and the infection curve and the economic situation in the past field, so past phase. So that would be better to have a dynamic optimization model. But with that, the parameters to be estimated will be exponentially increased. But so far, we are able to cut down the parameters to show this intuitively how this may work. But when it applied to the dynamic optimization problem, it will be having the same intuition and it only increase the computation, intensity of computation. Thank you very much.
This is fantastic, Dr. Chen. Thank you so much. And thank you so much for showing us such a powerful evidence and to show us the importance of cooperation. I also see from your recent interview that you also mentioned it is also of vital importance to strengthen the global collaboration to fight against the COVID-19 at this important moment. So we have already received lots of questions and it seems like our audience are really interested in your talk. So if you could take a look at all these questions, probably select 2 of the questions that you want to answer. So we're going to keep the time for you to answer this question after Dr. Yiwei Chen's presentation. Okay, so now let's turn over the mic to Dr. Yiwei Chen for the discussion of Dr. Shi Chen's presentation.
Thank you, Menxi, for the introduction. Can everybody hear me?
Yes, it's really clear.
Great. And my slides showing up?
Yes.
Cool, awesome, thank you. All right, thank you everyone for attending, and thank you for Dr. Chen to invite me to discuss this extraordinary and really interesting work. I really enjoy reading it, and I think it's super interesting and important. So because I think that many of the audience are not purely from economics background, so I'm going to water down my discussion a little bit in more like a layman's terms. So maybe I'm going to lose a little bit technical beauty of Dr. Chen's work, but I hope I grasp the intuition right. So the key fundamental trade-off we are really thinking about these days, particularly through migration, is that if we reduce the intercity migration from point A to point B, we're thinking about two competing effects. One is that you will have a decrease in number of COVIDs in destination, which is a good thing, but there's also a decrease of local economic activity, which is a bad thing. So really, we're really trying to think about how do we optimize this trade-off from societal perspective. So if I'm going to use oops, give me a moment. I think there's a technical issue. Am I still sharing my screen?
Yes.
Cool.
It seems like the reverse. Are you using your phone, Yiwei?
I'm not using a phone. This is not my.
I see. It seems like your phone, but
because I'm using a computer.
Right. You're not showing your slides.
I think someone else is sharing the screen.
Oh.
You may share your contents.
Yeah,
Try
maybe
to share your contents.
Okay, great.
Yes.
Mike?
Yes. Yes.
Cool. All right. So let's think about it from a visual perspective. So this is actually, I also grabbed this figure from Baidu migration. This is where people migrated to from Wuhan until, I think, the end of February. Actually, let me take it back, until the end of January. And the question is that, some city-to-city migrations have different or more or less impact on COVID infections and the destination economy. So we're really trying to think about, among all those between city-to-city links or migration links, what kind of links should we restrict? And we probably want to restrict those links with heavy COVID impacts and low economic activities, and preserve the others. So that's kind of, I think, that's the intuition there. And in order to optimally calculate this trade-off, the first thing we need to do is to estimate the intercity migration impact on COVID. So we need to understand when more people flow from city A to city B, that additional number of people, how many additional COVID cases it's going to bring to the destination city. So here, Dr. Chen and his co-authors, they actually use very parsimonious empirical specifications. They model a city's COVID infections as sum of intercity migration effects and within city traffic effect. So it's very simple. A city's number of COVID cases is just where it comes from two components. One is that how many cases come from the outside city, and second is how many cases occur organically from within the city. Then for the data, they use Baidu migration. They actually provide the migration data for both between and within cities for the past few months for the entire China. Now, in order to estimate the impact, they use a very clever trick in economics. So they use past year migration and weather conditions in other cities as the clean and exogenous, what we call instrumental variations to estimate the effect. So what does that mean? So if we think of it intuitively, we're kind of going back to the cliche causality versus correlation problem. So if you think about intuitively, when you actually just look at a correlation between a city's number of COVID impacts on one side and how many people migrate to the city on the other side, there's obvious a correlation versus causality problem, because when the city's infection rate goes up, maybe few people want to visit a city, or actually it could go the other way, because it's actually because more people visit the city, then the city's infection rate goes up. So those two effects kind of tangled up. So in economics, we have this clever technique called instrumental variable approach, that is to mimic or to find those kind of natural experiments. So ideally, we want to say, hey, in a natural experiment world, we want to hold everything else constant. We just randomly change the number of people who visit the destination city, and looking at how does this random variation affect the number of COVID cases on the other side. And that's exactly what Dr. Chen and his co-authors are doing. So they find some random variation. They think about it as, the past year migration number is kind of a random variation determining this year's migration number, as well as, the origin city's weather condition will also randomly affect the number of people who want to visit a destination city. So it's kind of through those random variation, they try to mimic a natural experiment so they can estimate truly what is the intercity migration effect and what's its impact on number of COVID. And this brings us to this very interesting and important graph. So let's look at the line, the graph here. The y-axis is total number of cases, and the x-axis is percentage of travel routes we can close in an optimal world. So what we see here is that if we only close like 5% of the travel routes, we are actually going to get closer, very close to number of COVID cases, even if we close like 100% of travel routes. So this is really saying, maybe closing all the routes is too much, and there's definitely some routes that's more important than others. So now that we have the effect of number of migration on number of COVID, then we can move on to the social planners problem. And in economics, we call it social planner. It's just a different term to think about a benevolent society. And once we go to benevolent society, we need to take a stance, what is benevolent society? And again, economics, traditionally, we take a utilitarian approach. That means we just aggregate everybody's preference together on the same unit. And here the unit is dollars. So what we are thinking is that, let's think of society is determine which routes to restrict so we can minimize the total cost of COVID infections across all cities and the cost of reduced economic activities from restricting migrations. So that kind of means we need to assign a dollar value on both the COVID infection as well as dollar value of restricting migrations on local economy. And here we have some key calibration parameters in this model. First of all, the paper assumed the total shutdown cost for intercity migration on economy is 40% of the GDP. So that means, I think that number comes from the observation that when Hubei closed down all its traffic from anywhere else, the economic activity shrink by 40%. So the assumption is if you close every single migration traffic routes, the GDP impact will be 40% of the city. And second is the assumption we make, the paper makes, is that the cost per infected person is about $1.6 million US. Now, under those two assumptions, Dr. Chen and his co-authors can calculate what would be the optimal decisions. So this graph shows the 50 routes with the most positive difference between what they calculate and what's the reality. So what they observe is that some restrictions are more important than others, and the most important restrictions are those origin cities that have higher infections and closer to outbreaks. And second is that destination cities that have higher or larger population outflow. The first and second point make a lot of sense because the first point basically means the origin cities you have a lot of infected cases in the origin city. You probably don't want them to go out. And second is in the destination city, if a lot of people tend to move out of these destination cities, then people will actually just radiate across the whole nation. So you probably want to think about whether to restrict inputs in inflows into those destination cities. And third, as Dr. Chen previously pointed out, if all cities work together, so that's what you mean by under coordination. If all cities work together, it's usually more efficient and more effective than if every single city worked by itself. And interestingly, what they find is that if every city under coordination, a quick and stringent restriction for the outbreak city, it will allow for more relaxed restrictions in other cities. So I'm going to give you a summary of the findings. First, I think this is fantastic data and modeling work to trade off like number of infections versus economic loss in the lens of intercity migrations. It's very innovative, interesting data collection, and they have very careful empirical strategies. What I think about the model is that indeed, I think a lot of people may question where this $1.6 million comes from, or whether this 40% of GDP loss is reasonable. I think, but those numbers, I don't think it's pivotal to this paper because the qualitative implications always hold regardless of the numbers. So I'm thinking about the model calibration part can be offered as a menu because people may just have different opinions on what a life cost is or what GDP loss is. And second part is, as Dr. Chen already mentioned, that they can incorporate risk aversion and nonlinear cost of the infections so that we can incorporate government's perspective that maybe they're really not thinking about number of infection costs as like 1.6 million as a dollar amount, but they're thinking about more like an increasing function, like one case worth that much, how much, and 10 cases worth that amount, but it's not necessarily linear. The one missing piece of the trade-off, I think, is that there's a people's self-willingness to travel. So we're focusing on the number of COVID infections on one hand and economic loss on the other hand. But there's something that's not captured just by the economic activity. For example, especially during Chinese New Year, people just want to go home. So there's a value of people's self-willingness to go home. I think it's lost in the trade-off. So last, I think I'm going to, in some way, preview the discussion or to ask some policy and challenging policy question to Dr. Chen and the other presenter in the audience. So we have very interesting and important economic findings. But I'm thinking from a policymaker's perspective, there are probably a couple of missing links that we want to think about. First of all, is to what extent is government to what extent is government risk neutral? So maybe government, what's their key criteria is not about expected number of infected cases. It's about how confident are we at ensuring a maximum X cases. So they're really trying to think about to minimize the potential impact. And often this X could be zero. Like they want to think about how confident are they at ensuring a maximum 0 cases. And second, because of the risk aversion consideration, then there's actually more importance on those traffic hubs where people actually migrate out a lot, because they will very likely boost correlated risk. What I mean by that is that if you have someone like you unexpectedly have COVID-19 and they've come to a city, and because there's a traffic hub, it's likely they will radiate the infections toward the whole nation. So the traffic hub becomes even more important under the risk aversionness. Third, I think this paper also try to position it as like in the future, how much we can learn from this. And I think this is very important lesson. But the question is that, especially during the onset of a new pandemic, how can government actually know what's the intercity immigration impact on infections ex ante? Because you see, let's say for seasonal flu, we may know this number very precisely because we have historical data on that. But for a new pandemic like COVID-19, how can government know for sure, or have eminent confidence to know what's the intercity migration impact? I think that's kind of an important question, especially during onset of a pandemic outbreak. So the government can decide what travel restriction they should have. And last is eventually, how do we convince policymakers and establish a system for the future? Like, do we want to be super quantitative? Do we want to be somewhat qualitative? How do we incorporate all the risk aversionness? How do we incorporate all the uncertainty that government does not know the pandemic impact up front? Or should we wait until we know some knowledge so that we will will implement this system? So I wonder, like, if today, how are we going to sell this system to the policymakers? And that's all for my comments. And overall, it's wonderful and it's really enjoyable reading. And I'm glad that Dr. Chen and his co-author work on this very important piece of work. Thank you.
Thank you, Yiwei. This is great. And I want to thanks for you to use the plain English to help us to better understand Dr. Chen's paper. This is especially important for someone like me who are not economist. This is great. I also really want to thanks for your thought in the last slides about these policy connections. You're totally right. And about your thoughts, how to convince the policymakers and establish a system for our future, like a pandemic. So, and I have been reading like great research recently, but this research has been barely reported by social media and also barely being accepted by the policymakers. So this is a great thought. And I want to turn the time to Dr. Xi Chen, and I want to know, like, do you have any thoughts about Yiwei's presentation? And I think you probably already read some of the questions from our chat. So do you want to pick two of the questions to answer, or you want me to pick two questions for you?
Sure, I will try to be very brief. Thank you, Yiwei, for very thoughtful and wonderful summary and questions. So we will try to incorporate your thoughts into our next version. So there are several things you talk about are key. For example, the first one is the lambda, the transmission, how widely this virus may transmit from this city to that city. So when having this decision-making tool for the government, for the decision maker, we really need to understand and know this number at the beginning in order to have those measures which route should be restricted or banned. So there are a couple of ways they could do. One is they could estimate empirically. So in our appendix, we show that we can use epidemiology evidence as like the physical reproduction number to calculate this number. So then the government at the beginning of a pandemic can have those numbers to suggest their decision making, to have their decision making. And also, since the government could be risk averse, as you mentioned, so they could be based on the decisions can be based on prior studies like similar or other infectious disease to make suggestions. So, for example, I remember in early February, the Economist magazine had a very interesting chart about all kinds of infectious disease and their basically production numbers. They give a range. So the government, if they are risk averse, they should take the highest number. So to assume that this outbreak would be very contagious because lives is above all. So they need to save lives. So they can make use of those numbers, the higher bound, the upper bound. And the planners can adjust for these decisions as new information come in, because we know that during this pandemic, more and more research come out, and we have a better and better idea about this virus and the parameters associated with this virus. So I think they can gradually improve, but they have to be more cautious and implementing more stringent measures at the beginning. And we also show that as you also mentioned there, like 5% of the roads need to be restricted. So that means even if the government take the most stringent measures at the beginning, maybe they are able to just restrict a very small share of those links between cities. So, so it may not be taking too much economic cost to save people's lives. And also, I think you were mentioning about the decision making. Yeah, eventually, we really want to have this as a decision making tool for each city government, because for each cities they can have their own parameters. Then they can have a list of city-wide links they should restrict with outside world. Then it's like a Jinlang. So every time when there's a pandemic or epidemic coming out, you can just check this list, whether they be this according to that, even if the restriction parameter may not be correct. But I think most often the rank would be quite accurate, because that's based on the historical travel data across cities. If you want to make it even better, you can use the travel history data not only for last year but last 10 years to have a weighted measure of city-wide links. So that will have policymakers to have more accurate measures of those travel restrictions. So in the interest of time, so I will talk to you later about your other comments. Those are wonderful comments. I just very briefly responded to two questions by the other audience. So they mentioned about what kind of weather variable we use. So first of all, we were using the weather data released by the U.S. NASA, NOAA, and Chinese authorities. They have a few category kinds of bad weather. So we group them together as the bad weather. So this is a standard treatment as other environmental studies. And we use the temperature, precipitation, wind speed as three instrument variable for the domestic transmission, infection, because this is based on our publication back in May in Journal of Population Economics. So if you are interested, check that article. We use a machine learning technique to find the most strong connections between the weather variables and those infections. For example, temperature, we all know that will affect the activity of the infectious, the intensity of infections in the area, and the wind speed and the precipitation. The humidity is also a major factor about that affect the transmission of those viruses. But we were using data-driven methods to find the strongest link, and because the first stage was very important, we try to make sure those weather patterns strongly predict the CTJ infection. Then we can estimate whether CTJ and how much CTJ can be contiguous to CTI. So that's the first stage and second stage. So please check that article. And I think those are the two most commonly raised questions about this people from the audience. Thank you so much.
Thank you so much, Dr. Xi Chen and Dr. Yiwei Chen. This is wonderful, and I really appreciate for your presentation and also discussion. Okay, so now let's turn the mic over to Dr. Winnie Ye. Dr. Ye, please. At the same time, and Dr. Chen and to Dr. Chen's, I think our audience also left some questions for Dr. Yiwei Chen. So if you could take a look at about these questions, probably reply to our audience, that would be great. Thank you. Okay, Dr. Ye.
Can you hear me?
Yes, it's really clear.
Great. First of all, thank you very much for inviting me to speak. And I want to compliment on the great work that Chen Xi has done and the comment that Yiwei has made. And it actually provides a great segue into what I'm going to talk about. When Dr. Bao invited me to speak, I said I will not be presenting a specific study, but rather to share with all of you some thoughts of how some of the very great modeling work and the great advances in estimation technique and also data collection might help to inform policy making. And so I have titled my talk as Integrating Analysis with Decision Making. And I'm just trying to provide some reflection and food for thoughts for all of us to discuss about, which might be useful for you to think about what kind of modeling and empirical exercise might be useful, and also as a way to think about what might be some of the next strategies of data collection and also engaging the policymakers. So the basic question that I'm raising is, how could we better prepare for another future pandemic? Or to say it differently, how can we learn from COVID-19 so that we can do better? And by better, I measure that by reducing or limiting the negative consequences on human well-being. And I would like to remind all of you to think about human well-being in a much broader sense, in the sense that human well-being has really many dimensions. For the poor and low-income people, we are talking about basic necessities. We're talking about, do they get food? Do they get housing? And the impact of impoverishment. I think that some of the work that is presented next week will be focusing on poverty. But if you think about basic human needs and well-being, then one should really start with the very basic necessities. For those of us living in the United States, maybe that's not very obvious. Living in China, maybe not so. But if we would telescope ourselves to think about India, Africa, those are really key issues. Health is an important aspect, but we should not forget about our psychological and mental health well-being, which I think is a very significant impact of this COVID-19 impact, unlike previous other infectious disease. Cognitive development, very important for children, and the consequences of school closing and the separation of their socialization. Security, once we have health, once we have basic necessities, we're all yearning for some sort of security. How is security being taken away from us with COVID-19 and the opportunity to grow as well? So I'll come back to this a little bit later. So I'm putting myself in the shoes of a policymaker. If I'm a policymaker, what would I want to know if I'm going to be able to prevent another crisis like that in the future? So this is a diagram that I'm sure many of you have seen it, and it's basically a diagram showing the epi curve of the Wuhan situation. The purpose of me showing this slide is not really about the detail on that graph. You don't need to pay attention on the details, the day of that. I'm an economist by training, but I'm also surrounded by virologists and epidemiologists colleagues. Everybody, what we're trying to do is, how can we, during this period of time, be able to use information, data, to inform the policymaker in a way that actually speaks to their concern and trade-offs, so that we can curb the growth. And that's a different idea than flattening the curve. Flattening the curve, eventually, you still have the spread of cases, but you're just extending it over a longer period of time. Can we ever actually curb it somewhere that it would not even continue to grow? It's a very ambitious question, but that's the question that I think most policymakers want to know, because all the later discussion on lockdown, on draconian policies that have made a lot of effect come at huge cost, great cost. So every time when you reach this stage, you have to confront difficult trade-offs. Is it possible, if we have another outbreak in the future, that we can avoid getting up on the exponential growth path of the curve? The difficulty comes at because it is a new disease. It has lots of unknowns. It had lots of uncertainties. And imagine in the beginning, we didn't even know whether it is human-to-human transmission. And once it is confirmed, we still don't know how contagious it is, how deadly it is. And these data are only gradually being available. And even a few weeks ago, we're still debating whether there is asymptomatic transmission. And we're still debating about airborne. So learning, so how do you incorporate into your model these differences, which I am sure that many epidemiological models are trying to do that. But the critical thing is, how do you take it from the model to the decision maker in a way that it addresses their concern that they can take action sooner rather than what happened this time? And I always paraphrase it as, how do we prevent another Wuhan in the beginning? How do we prevent another New York in the future, and so on? So I thought that come to me as in the in the circle that I interact with, work with, that tends to be a lot of policymakers and people who think about strategies. A number of people have drawn parallel of the COVID-19 virus as if we are in a war. But if we're in a fog of war, that is, in the very early stages, we're fighting this virus, but with a lot of uncertainties. And we hear people talk about testing as a way of gathering intelligence. And how much of the intelligence do we need to know to help the strategists to make decision of where the enemies are, when they might strike, and how big it might be that strike? And different people have now drawn parallel of the COVID-19 virus to war in terms of the scale, the speed, and the spread, and the potential impact that crosses border. Part of me feel, can epidemiologists and economists have a conversation with military strategists to think about how they make decisions when they face a lot of unknowns, and make our empirical work and estimation models and data collection that might be more closer to the decision maker. Just a random thought. I don't know the answer. In terms of the impact on health, right? Remember earlier on, I said that there are multiple aspects of human welfare, and health is one of them. At the present moment, we are focusing very much on the direct impact of COVID. And last week, I understand that there's already some discussion on looking at the impact of the non-COVID patients. I didn't draw this graph. Someone else has already presented this. But I think it is a good way for us to really think about what are the impact on the non-COVID urgent care, and then separately for the chronic conditions. Without looking at that, it is very difficult for us to have a systemic and comprehensive assessment of the impact. And therefore, what are the strategies that would look at the trade-offs among these impacts? And what I think this diagram is also important is this line that is looking at the psychological impact. And I have never seen other infectious disease pandemic that has as much of a psychological impact as this one, and as widespread. And we really need some concerted effort to collect the right information and data to try to understand that scale of the effects. I think that there are some emerging evidence looking at the second wave on my previous graph, that is the urgent care. This is a paper that, it's not my paper, but it's a paper that just came out in the latest issue of The Lancet, showing that in England, during the outbreak, the number of admissions for heart-related conditions, and this is the number of admissions for heart attack, the different types of heart attack, it was reduced by about 50%. And the consequences of these reduced emission, whether people have died, whether people have not gotten the interventions and therefore have suffered long-term consequences, it is still not quantified or analyzed. And they are very important because remember, most of the countries that we're talking about, whether developed or not developed countries, face huge burden of disease of cardiovascular. And this is showing that the reduction in important invasive procedures, including bypass surgery or a balloon, percutaneous infection. So again, huge reduction in services. I myself also doing some analysis with ischemic stroke in China, and this is very preliminary, so don't quote it. And we try to look at the same week in 2018-2019 compared to 2019-2020. And so this is the line in terms of the number of admission for ischemic stroke, and this is the line for this year. And you see that the gap is diverging rather rapidly, and this is overall in China, so it's not just Wuhan. So again, if we look at the share of the people who have not been admitted compared to those who were admitted before, yes, those who seems to have been facing foregone admission tend to be the less severe ones. But again, for stroke, we know that if they do not get immediate treatment, even they are at a not severe stage, the long-term consequences is really huge. And so some of these evidence are just beginning to come in. And I look at last week's talk, there is a frustration of, the data is not available, but I think that's where we have to make some concerted effort. And beyond these, there are major consequences. Preventative services, immunization and vaccination, delayed diagnoses for different kinds of screening. And I would again point out for low and middle income country, things like TB, HIV/AIDS, even basic maternal child health nutrition program has been severely affected. And again, we're just beginning to hear some of those consequences, and more formal data analysis are yet going to be coming in. And I do think that when these information are available, it will be so important and significant to incorporate in any simulation and any projection, because they are part of human welfare. Let me just skip that one. Now, let me turn to this question about health system. There are a lot of people who were saying, well, what do we learn about our healthcare system? And from this COVID outbreak, what is the reflection or what is the reform of healthcare system that we should be thinking about? And one of the question is, shall we build more hospitals? Because I think this is very much driven by this conversation that we have had many weeks on that, how do we flatten the curve? And flattening the curve so that we are beneath that capacity. But very often when we're talking about capacity of healthcare system, we're talking about the number of beds and number of ICU beds. And that is the acute care section part of it. So I saw this just 2 days ago from a WeChat from China. Wuhan in one day launched building 6 major hospitals, medical centers. Each one of them is over 1,000 beds. If we think about the resource allocation in China, already 57% of the resources are concentrated in tertiary hospitals. I think it is an important question for us to think about. What should we do for the future? Shall we be doing more hospital building? This is a very enlightening table from Italy. And I'm sure most of you have heard that. the experience from Lombardy versus another province, Veneto. And the major difference is, of course, one, the infection rate, two, is also the case fertility rate. The major comparison that scholars have been doing is Lombardy uses a hospital-based management approach, whereas Veneto uses an out-of-hospital approach, primarily relying on community, trying to keep people out of the hospital, give them tests, quarantine them, tracing them. And again, also, China actually has a very effective strategy, which Chinese is called 网格管理, which translated to, again, managing through organizing community. I think COVID-19 bring out a very, very interesting comparison between a more hospital-based approach versus a more community-based approach. And I do think it is ripe to try to model the relative strategies of a country can use that actually might impact the effect of it. And also modeling what if country actually were able to build up its primary health care to be stronger, to be able to take some of the function that in the early phases are actually done by the hospital, to have people's trust in it. And I think it is very important at this point to begin to think about the relative trade-off between hospital versus primary care, hospital versus communities. Community is definitely broader than even primary care, because it is going to be very important in helping government to think about resource allocation for the healthcare sector before it goes down the wrong way. Economic impacts. It's still early, and we have seen a lot of great work looking at economic impacts, but I would urge that economic impacts have to go beyond GDP. And distributional impact is very, very important by socio-economic group, and in the case of the US, race, ethnic groups. And again, I want to emphasize that for low-income population and low-income countries, it is whether people are even able to maintain a certain livelihood, poverty. Are they getting food? Are they getting nutrition? Are they getting housing? GDP alone just doesn't capture those important nuances. And also, it actually doesn't also capture what are the interventions that you can actually keep a population to be able to maintain the bare basic living, which cannot be measured by GDP. Children, we measure about schooling. We have to think about the impact on their cognitive and social development, because in the long run, all these are important in affecting the economic development as well. I'll just conclude with one slide, which actually Chen Xi and Yi Wei have both mentioned about government. I'm very pleased that Chen Xi's analysis tried to look at coordinated government decision versus non-coordinated, which is very reflective of the US situation. But I think that there's something even a bit more complicated and nuanced. This diagram is a very simplistic portray of the governance structure in China. After SARS, the Chinese government built a very sophisticated reporting system to have direct real-time report from any suspicion of infectious disease that would go to the CDC. But from that point on, the decision-making still has to go through between CDC and the government and the health bureau, and in between the health bureau and the government, and between each different level of government. I would urge us to think a bit more, if we're trying to help a country or even at a global level, we have to understand who make what decision at what level at what time, so that our modeling exercise, our data collected, can be targeting at which decision maker. That's number one. And number two, I also want us to think a little bit about a different governance structure would mean that there are different time and delay between something that is reported to some decision making. And how do we incorporate it in our model to think about different governance structure that might actually release or reduce that delay, that might actually help to curb the growth of the virus that I show in the first graph. This is a little bit probably further away from what we have been thinking about in epidemiology model and even in economics model. But I feel that if our results are going to be useful and to affect decision making, we have to have a better understanding of the decision structure of it and how we can help to reduce the delay in that governance structure. So with that, I will stop. And again, I want to compliment all the wonderful work that you all are doing, including the participants, and it has made huge impact. I have just shared a few thoughts of, if I'm a decision maker, what would I like to know more and how the analysis might enhance that decision making. Thank you very much.
This is fantastic, Dr. Ye. Thank you so much for sharing your perspective and thoughts regarding decision-making during the pandemic. It also provides us lots of thoughts regarding research. As you mentioned while you were talking about health footprint of COVID-19 pandemic, it really made me thinking about, like, when you were talking about the psychological impact of COVID-19, I'm working on a research to measure the impact of COVID-19 on refugees. And I do find that around almost 30% of the refugee population experienced a different type of discrimination during the pandemic. That definitely gave me some strength and power to continue this research to talk about the long-term impact regarding their mental health. Thank you so much, Dr. Ye. Okay. So let me turn it over to Dr. Cai. And Dr. Cai is going to have a short reflection about Dr. Ye's presentation.
Thank you. Thank you for your invitation, and thank you all the speakers for wonderful talks. The one thing that I'm happy about after sitting here listening to all the wonderful talk is that I'm no longer a member of the academia. I don't have to sweat myself doing all the hard work, and I'm just sitting here enjoying critiquing other people's work. So that makes me a little bit happy. So I think Winnie touched on a lot of good points, and she raised two important questions. One is a policy question. The other is an empirical question. The policy question is how to make the most effective policies in the face of the greatest uncertainty with limited data and a lot of constraints. And as the experience we've all experienced and observed in recent months, you can see that policymakers don't operate in a vacuum, and they not only face the scientific uncertainties, but also they are facing a lot of constraints, and sometimes opposing constraints like public health and economic. And so it's very difficult that they are trying to maintain a balance of achieving these opposing goals simultaneously. And sometimes, for the convenience, they will just sacrifice one and just for the sake of the other. And so that's one of the challenges that all policymakers face. But I think I want to turn my attention to the empirical question. So I find it very interesting that Winnie has used a diagram to talk about the possible ways in the aftermath of the pandemic. The first wave being the burden on the COVID-19 patients, and then the burden on the non-COVID-19 patients in the psychological and physical health burdens. I think these are the things that, you know, whether we are policymakers or policy analysts are interested in, is that, you know, how do we attack these questions empirically in the best way? So one thing that we did in the Office of the Actuary is that we go around and look at different sources of data and try to answer that question empirically, although not perfectly, because a lot of the data sets that were prepared are not prepared specifically for this type of a scenario. So what we did to answer that particular question is that when we were building a gigantic COVID model, one of the questions that we had to answer is that what's the intensity impact of delayed care, which means that if somebody's somebody missed a certain preventive care screening and waited like 4 months to be able to see his doctors again, or somebody's with multiple chronic conditions and delayed regular monitoring or in-person visits to his primary care physicians, then what kind of impact would that have on that patient physical functioning and also health conditions 3 months down the road? Will the situation become worse and will cost the healthcare system even more to treat the patient? Like most recent Kaiser family survey shows that about 48% of patients were experiencing some kind of delay of care, but most of them seems to be non-significant delays, and they report only 11% of that 48% were experiencing worsening symptoms of their chronic condition, and so this is something that, you know, we are also need to keep in mind. Well, one thing that we did empirically is to go back to the MEPS data, which is the Medical Expenditure Panel Survey, to look at what happened to people who experience delay of care. Although in the MEPS data, the delay of care occurs for a variety of reasons. They might be because of the cost of care, because of access of care, or because a variety of different reasons. So we look at that particular variable and divided the sample persons into 2 different groups, delayed group and non-delayed group. And it turns out that after this some simple analysis, it turns out that the delayed group experienced a 6% higher intensity of care than the non-delayed group. So if you take that into account and consider that, you know, for Medicare patients, at least for Medicare patients, during the first 3 months of pandemic, you know, the care volume and utilization has been down almost 40–50%, but the spending is down about around 30%, if I remember that correctly. So and not all delayed care are completely foregone, and some of the delayed care, actually, you can see from the Kaiser family survey, is that 75% of the respondents they expect the care to be resumed within 3 months. So they expect to see the doctors pretty soon after the physician's office are open again. So it seems to be that different sources of data seems to be pointing to the fact that the delay of care might not be causing a significant amount of increase in the burden and also the expenses of treating those patients because of the delays. And so one of the questions I have for you and maybe for others is that, you know, what are the best way to attack these questions empirically, and what are the best data sources in the U.S. that we have that we can have access to that can help us help answer this question more scientifically.
So I want to quickly just respond to this. I mean, just to discuss this. I think this is a very intriguing question, and I think it probably would be the answer would be very dependent on the starting point of a healthcare system. You know, the US actually, I think what you were saying seems to be consistent with what I'm hearing from other researchers who are not seeing major evidence yet that it has significant impact on delayed care in the US. I wonder if one of the hypotheses is that even in the baseline, the US utilization is a little bit tending on the excessive side. And I think this will be very different if we take it to a situation like India, like I would say even the UK, where use of acute care services is much more constrained and conservative. So it's a great question. It's very dependent on the situation. Now, some of them might be even delayed care and have no impact on health outcome as well. But I think these are important to assess so that we can have a complete picture.
Right, I agree that the point that you raised is very important, that the U.S. probably starting off at a very high point, maybe a little bit too much care already.
Yeah.
And so trimming off a little bit fat probably is not going to hurt that much.
Mm-hmm.
And also one of the things that I want to mention is that, you know, although a lot of the although there's a huge decline in in-person visits, but there's also a huge increase in telehealth, which substitutes for a lot of the decline of in-person visits. So that to some degree will moderate the impact of the delayed care as well. Right.
So on that, now again, we need to have more empirical evidence, but let me, that's the slide I actually skipped.
Right, yeah.
So this is from the US, but I think it's only from a health plan, which this is showing the reduction in offline visits, and this is the increase in the online visit. The scale is different. The offline visits, actually, the online visit, which only make up a not very sizable proportion of the reduction in offline visit. But again, does the US start with overusing? We don't know. I am looking at some China data as well. I think that the online visit probably only make up, again, a not too big proportion, less than half, definitely, of the offline reduction. But China also started with using too much sometimes. So we have to really get to the details of how much of that is really having a negative impact.
Yeah, I think in political.com, there's an article, maybe today, maybe yesterday, there was a similar figure from 37 different healthcare systems in the US. Mm-hmm. So I think everyone's seeing the same thing.
Mm-hmm, mm-hmm.
It's yesterday, actually.
Yes, I think it's interesting to see that these patterns are emerging. I mean, even the earliest slide that I showed that in England, the reduction in admission for cardiac patients, the reduction is about 50%. The data that I'm analyzing in China for ischemic stroke is also about 50%.
Mm-hmm. Yeah. Yeah, it's very interesting. So
I think with more of them being done, we might be able to have some converging evidence that give us a bit more information.
I'm sure, yeah. When more data comes in, we will be able to have a better idea what the real impact is. Okay, I think my part is done. I think my thoughts are very limited, and I think so. I'm happy to turn it over to whoever wants to ask more questions.
Thank you so much, Dr. Cai and Dr. Ye, for those insights. They are wonderful. And Dr. Cai also mentioned he's not working in academia anymore. But as I mentioned, he's the economist at the Center of Medicare and Medicaid Services. So we have some audience who are not in the US. So I just want to give you a little bit of background about the Medicare and Medicaid. So Medicare is a federal program that provides healthcare coverage for elderly population who are more than 65 years old. And Medicaid is a state and federal joint program that provide health coverage for those who have very low income. So Dr. Tsai, I actually have a question to you, especially focused on the Medicare and Medicaid. So I have been seeing like several discussions, or actually lots of discussions regarding Medicare and Medicaid and how these two federal and state program could support people during the pandemic. And you also mentioned like in your set, researchers also doing research to understand the need from the patient. So I wonder, through the current research, and do you see like any changes or potential changes could be due for Medicaid and Medicare regarding COVID-19?
Well, I think one of the biggest change during the pandemic is the waiver of telehealth, the waiver of numerous restrictions on telehealth, and they did a lot of work to allow Medicare and Medicaid beneficiaries to have easier access to the doctors through either real-time or asynchronous interactions with their physicians. So that creates a lot of new ways for patients to still maintain their some degree of access to the healthcare system. So that's why I was saying that that might offset or moderate the negative impact of the drop of in-person care. I think recently the Congress has been talking about making some of the temporary changes regarding telehealth permanent. So for example, they will relax the restrictions of the originating site. For example, they now, I think in the proposal, in the congressional proposal, they now allow people to see their physicians from their own home, which was previously prohibited. And they will also allow telehealth to be conducted not just by physicians, but also by physician assistant, licensed nurses under maybe not direct supervision of the physicians, but under general supervision. And some other restrictions could be relaxed as well. But one thing that seems to haven't been really discussed is the pay parity. During the pandemic, Medicare pays the telehealth visit the same rate as the in-person visit. So the latest congressional proposal hasn't really mentioned whether pay parity will be maintained, because Congressional Budget Office, which is the official government agency, congressional agency to score all congressional proposals, still maintains that in a general situation, telehealth still will increase government deficit, because a lot of times telehealth were being used not as a substitute to in-person visits, but to be used as an addition to in-person visits. So unless their position changes, it's very difficult for Congress to pass any laws to relax the restriction, to remove the restrictions of telehealth significantly. So I think that is still an ongoing issue, and there's still a lot of debate on both sides. And I think we'll just wait and see how it turns out.
Right. I think telehealth, there's a parallel development in China as well. You see, COVID-19 is interesting. Also, of course, it's causing great damages. But on the other hand, it is also pushing forward some of the things that are already happening on the peripheral to the core. And I think telemedicine is one of them. And similarly, I mean, in China, during the outbreak, many of those visits are free. And now the government is actually issuing policies to make it formalized that social health insurance might consider actually covering telemedicine. I see one of the question in the chat box is about telemedicine in the US. I think that telemedicine is providing great convenience. There's no question about that. But for the next step, it does require more study and regulation on standards of care. And also referral pattern between online, offline, whether there is tied financial interests, all of those need to be understood better.
Right. And also, one critical difference between US and China is that the US allows telehealth to be used as a means for initial visits, but China only allows for telehealth as a means for return for follow-up visits.
That's right.
And so that's one critical difference. And I agree that there's a lot of technical and policy things to be considered, and especially the prospect of greater fraud to be conducted in telehealth. And I think that's a common problem for both China and the US. It's a huge challenge how to combat, abuse and fraud of telehealth.
Thank you, Dr. Ye and Dr. Tsai, for talking about the telehealth and also compare the differences between the telehealth development or usage in China and the US. And I didn't know the difference before, so it's great to know. Okay, so
may I have a comment and a question?
Yes, please.
Yeah, I saw Winnie's slide. I think it's a very important slide about the 4 waves of impact and the footprint of COVID-19. I think there could be another 5th wave, which is ignored. It's about social determinants of health. So given this pandemic hurt the economy, so there won't be a V-curve recovery. This may take a longer, even the air curve. So the unemployment, and now I think recently the Congress are debating about whether the $600 US dollars insurance benefits are still being put into the new package to send to individual families, because people don't want to go back to work for some occupations because they earn more than they did before the pandemic. I think those are and higher and unprecedented unemployment rate. I think those will have a ripple effect or reinforcing the COVID impact after this pandemic. It may take a much longer time than the impact of delaying care, all kinds of all the PTSD type of mental illness related cost. It could be like having this ripple effect. So that's my comment. So the question to Winnie is, through this pandemic, we know that for all systems, especially like US, China, we see the weakening health, public health system. And today, the CDC director mentioned that they have been like weakened, and the investment should be starting from today. But we know the public health is having a unique feature. When the public health is doing good, then it's not quite visible about their achievements. Unlike medicine, so when we have breakthrough, the cost of healthcare is increasing and the people lives saved. It's not as visible for the public health. So after this pandemic, your thought about how to strengthen the public health. We know this is a weakened and much weakened compared to the other 2 angles. We usually see basic medicine and clinical medicine. So if the public health side is weakened, this triangle won't be balanced. And to Li Ming, also your thoughts about whether the federal government may have any plan to increase reimbursement, changing the incentives to better tackle this public health crisis, because we know the scale, the depth of this issue is so unprecedented. But our measure currently is so low. The CARE Act only give like less than 8% to public health measures like contact tracing, testing. But the reduction, the contraction of the GDP is much higher than that. So would we have more spending towards those public health initiatives? Thank you very much.
I'll leave the US question to Dr. Tsai. I think that this outbreak actually in China, at least, has elevated the importance of public health significantly. So, I mean, if you look at all the School of Public Health now, definitely is getting a lot more attention. I understand many schools of public health are getting more slots for hiring, more slots for students, but my point is this: money may be one of the cause of poor public health, but money doesn't solve the problem. I think that in the case of China, it requires a system level change so that public health is actually also integrated with medical decisions in a way that is coherent rather than as two separate decisions. And resources need to be more coordinated. And if you ask me, China's current effort of trying to develop integrated delivery is a good way to go. But what we have seen, a lot of the integrated delivery system is actually hospital-led. Now, that's unavoidable because primary healthcare is very weak. So, but there are innovative ways for you to make the hospital held accountable for improving public health. I think that has to be something to be seriously considered. Otherwise, resources will still continue to be sucked into the hospitals, as I show the 6 huge hospitals that will be built in Wuhan already.
I'm going to chime in on this. So I think what's unique about public health is that it's so rare. Like a public health event is so rare. It's not like chronic disease or regular medical disease. We see it every day. So we can, like, even we have the best intention, we'll build a new system. Like we can see whether medical spending reduced tomorrow. Like we can see it right away. But for public health, it's such a rare event. Let's say even every country has the best intention. What would be the mechanism to know we are doing the right thing? So I'm going to throw the question to all the presenters.
I think you're talking about emergency rather than general public health, right? Public health should be a regular, everyday thing.
Yes, thank you for clarifying.
And yes, you're absolutely right that after a while, I mean, right, SARS, when China have SARS, all the attention is on it. And 17 years later, and I'm sure, I mean, it's just human being. We thought that is so far away from us. And I would let Dr. Tsai talk about the US situation. I mean, Obama has actually set up a separate fund, a separate unit that you can trigger that to happen. So earlier on, Chen Xi mentioned about Taiwan. Taiwan has an interesting system, which I think that many countries can think about. It's almost like an alarm system. So the alarm system would get triggered off to be third level importance. And of course, that would have to depend on, they have to have the information and the data coming in. But that's sort of like a very moderate level. And they would have the CDC director making certain decisions, have certain authority to do further data collection and whatever. And then they have a very clear guidance on when it would have elevated to the next level. Then it is actually the Minister of Health who would also have the Minister of Finance and also Labor and the equivalent of them sitting at the same board that would make other level of decision. In other words, you have to build a system. It cannot be dependent on you strike the alarm and then it's one or two individuals making that decision.
Actually, I don't know much about public health, so I don't consider myself an expert to comment on whether the U.S. should increase investment in public health. But I think one of the difficulties that the U.S. faces is that the system in the U.S. is set up against public health, basically. You know, all the medical systems is set up against greater investment in public health. People here just take more pride in treating people instead of preventing disease. Although I have to qualify that is that the transition now to value-based care is changing, turning the tide a little bit. But so far we haven't really seen any promising evidence of this being a successful effort in the aggregate. So I'm not positive of whether success in public health is gonna happen in the U.S. anytime soon. But on the other hand, during the pandemic, actually, a lot of the U.S. system is being, even though you can find a lot of faults with the U.S. system, but one thing is great is that it's very flexible. So even though you can name many different limitations of the public health system in the U.S. is that during the pandemic, one thing it shows is that it's very flexible in mobilizing military forces to come in to shoulder much of the responsibilities that should have been done by public health professionals in many other countries. So I think the semi-militarized operation in the U.S. during the pandemic is one example of, the government can mobilize resources from different branches of the government, many different agencies, and put them together and organize, for example, by FEMA to mobilize a very efficient force to deliver the care that's needed to wherever it needs the most. So I think one thing that you will find comfort in is that the flexibility of the U.S. system in addressing the limitations of its existing public health system.
I just one last thought. Public health, again, I use that analogy of a war, because public health is something that is not affecting one individual. It's not something private. It's something that actually have a population-based effects, which means that any individual decision may not be internalizing all the consequences. What Obama has set up is there's a commander-in-chief kind of system that would kick off during these crises, and that is completely missing in the U.S. this time to coordinate. And that's missing in the U.S.
Maybe he was fired by Trump.
It was taken away before the pandemic strike. Yes, unfortunately, and the money that was put aside that would be available whenever there's a pandemic was also repurposed.
Yeah.
Thank you for the great discussion. Since we're reaching 11 p.m., so we will let our discussion and also our presenters to rest.
Yes.
So and thank you so much for everyone's perspective for this great discussion. And I totally agree with your thoughts, and especially with Dr. Yin mentioned, money doesn't change public health. It needs a comprehensive system change to improve public health. We don't see it just in China, we also see it all over the world. And this also reflects Dr. Chen Xi's presentation that collaboration could help us to fight COVID-19. Again, I want to thank again for our presenters and discussant. You have been amazing, and also I also want to thank for the China Data Institute and the Future Data Lab, as well as China Health Policy and Management Society for sponsoring the webinar series. And many thanks to you, our listeners, for joining us today. I have seen that you post lots of questions that we probably not able to answer all of them, but please do continue the conversation through our WeChat lab or through our WeChat group, or you can also please feel free to email us. Thank you so much. Our next webinar. Thank you. And so here's an advertisement. So our next webinar will take place in 1 week on July 30th from 9 p.m. and 11 p.m. Eastern time, exactly the same time. So we look forward to see everyone the next time. Thank you.
Thank you.
All right, thank you. Thanks, Mengxi, for your excellent coordination.
Thank you, Dr. Bao.
Thank you, everyone. Have a good evening. Have a good.
Thank you, everyone.
Bye-bye.
See you next week.
See you next week.